Hello and welcome to this Vulval Pain Society live on Bladder Pain Syndrome. I'm Sheren Gaulbert, Vulval Pain Society Trustee, therapist and pain science educator. Please say hi in the comments if you're watching live so I know that you can see and hear me fine. I've kind of gone into soft focus, forgive me. The main focus is going to be our speaker today, and we'll see if I can sort out my camera in the meantime. As always, pop your comments or questions in the box as we go along. I can see the room is filling up with people. Hi, everyone. Thanks for joining us. And Kay Thomas, our operations director, will be keeping an eye on your comments and questions on Facebook. And Catherine will be on YouTube for us. I'll also keep an eye on comments too. Guiding us, informing us, is our very own Dr. Winston de Mello, pain medicine consultant. Hi, Winston.
Good evening, Sharon, and good evening to all our listeners on this live broadcast.
Hi, Winston. I mean, it's good to see you after our little summer break. Are you well?
Yes, thank you. And you?
Good. Yes, I'm super. Apart from being in fuzzy focus, I'm okay. It's hiding all manner of sins, so... Now, we're all set to learn from you. So I would say let's just dive straight in, if that's okay, Winston. Mm-hmm. Straight into what is bladder pain syndrome, and is it different from interstitial cystitis?
That's a very good question. Bladder pain syndrome is a spectrum of disease, a chronic condition of the bladder, which causes pain mainly in women. Men are 10 times less likely to have the problem, and that is because the urethra in a female is shorter than in the male. Now, bladder pain syndrome is a spectrum, and interstitial cystitis is an extreme version of it. Now, I'm quite clear that the diagnosis of bladder pain must be made only after disease processes have been excluded. What I'm thinking about is things like recurrent urinary tract infections, other disease processes that may be going out in the bladder, or bladder stones, etc., etc. So it's a diagnosis that should only be done after a urologist or a urogynecologist have excluded treatable processes that also cause bladder pain. So the question is, where does bladder pain occur in the body? In the lower abdomen, above the suprapubic bone, but occasionally patients will find discomfort in closer areas like the urethra, vulva, vagina, or rectum. But essentially, it's lower abdomen. And the pain feels like a pressure as the bladder fills up with urine. Now, when the bladder fills up with urine, it is the bladder wall is muscular. So if you're irritating the bladder for whatever reason, then you will develop urgency, like you need to get to the loo now, or frequency, going to pass urine more often, either in the daytime and including nighttime, which you can imagine will impact on your sleep and quality of life. So the definition really of bladder pain is pain in the suprapubic region related to bladder filling and have an increased frequency of daytime and nighttime urination in the absence of a disease. So that's the simple definition. Now, you may think, oh, why are we discussing bladder pain in the Vulval Pain Society a podcast? Well, it is true that if you have vulvodynia, you're likely to have other comorbidities like IBS, fibromyalgia, tension headaches, migraine, endometriosis, and bladder pain. So I thought it would be a nice topic to educate our patients who may or may not know what coexisting pain syndromes a woman may have, because she's already focusing on the one that's causing her primary problem. So that's why I think it's an important subject.
Okay. So you talked about this pressure feeling as someone fills up, so urine kind of fills the bladder, and frequency and urgency. Are there other symptoms of bladder pain syndrome? Because you say it's a spectrum. So is there a variability in those symptoms?
No, I think it just varies in severity. So you may get the occasional cystitis-like sensation on one extreme, which is transient and may not occur. And then on the other side of the extreme is the very severe form of bladder pain, which is interstitial cystitis, where there is definite changes when the urologist looks up into the bladder during cystoscopy and sees blood vessels or ulcers that are pathognomic of IC. So if you like, it's a spectrum. Most women will have some transient experiences of cystitis-like discomfort, and interstitial cystitis is the extreme. Okay. So it varies only in severity.
Okay, all right. And what causes this in the first place? So bladder pain syndrome, or IC, that extreme, what are the causes, and are there particular triggers?
Well, I'll take that question in two sections. The first is, do we know the cause? The honest answer is we don't. There are so many potential causes, hence the potential remedies or treatments that are possible. But let's look at the common ones. If you suffer from a recurrent urinary tract infection, you're more likely to develop bladder pain. If you have the inner lining of your bladder damaged, and that's called the GAG layer, that means that urine, which is acid, can then splash on the nerves and give you bladder pain. So if you like, the inner lining of the bladder, the GAG layer, if that is denuded or removed, like paint coming off your wall, then you're more likely to get pain because acid is irritating the nerves that follow the bladder. Pelvic surgery may also cause it. You may have an increased sensitivity of your bladder nerves. Or it may be that there is an increased amount of mast cells that release histamine, which is one of the reasons why some patients get benefits from antihistamines. So what I'm trying to get across, although the result is the same, i.e. bladder pain, the causes could be multifactorial. And it's really a question of trial and error before an individual patient finds what's best for her. Now, the triggers, which is the other question, it's interesting because the same applies to patients with vulval pain. You avoid the obvious triggers, and these are really in what we eat and what we drink. Coffee, tea, fizzy drinks, beer, red and white wine, champagne, citric fruits. There's a whole list, including some of the additives in foods and sugar substitutes are sort of the common ones. And the recommendation is by doing an elimination diet, you find out what triggers your bladder pain and eliminate them if they are an obvious cause. So I think it's a question of trial and error. On the flip side, one of the best things is actually water. Because if you drink sufficient water, you dilute your urine, and you can use the color of your urine to ascertain the degree of hydration of your body. So if you aim for your urine to be very light straw-colored, then the chances are that you're well hydrated. But if it is strong and dark in color, like the first urine sample early in the morning, then you obviously need to drink a little bit more. Hence the popularity of people drinking water. Some foods like milk are good, bananas, certain fruits like pears, vegetables like broccoli, Brussels sprouts, cabbage, carrots, etc. are all also good. Again, I think it is true to say that it'll vary from person to person as to what foods and what drinks make them worse, trigger, or make them better, or not as bad. So again, I think it's a little bit of a trial and error, and trying to eliminate those triggers and trying to incorporate in your diet and sort of way of living good general health, i.e., being well hydrated, especially in the hot weather, or if you're going to a hot climate for a holiday. Those are the kind of high risk times when you might be more prone to getting problems with your bladder.
What's that about, Winston? Why is going to a hot country or hotter weather?
Well, I guess it's a mixture of things. You're more likely to be sweating. You're more likely to be drinking alcohol, which is a diuretic, so you dehydrate yourself. So there are lots of reasons as to why you may get dehydrated, or you may be limited in getting hydration because you're traveling or because you can't get to a toilet. So there are lots of possible factors, but those are the main ones.
Okay. I'd like that you said there's going to be an element of trial and error here when it comes to diet, because you mentioned that, you know, there's many potential causes and everyone's different. And one of the causes might be that increased histamine release. And of course, some of the foods that might be beneficial for some people might not be beneficial for those people who have that increased mast cell activation.
Exactly. And I think this is why one size does not fit all. I think every individual patient needs to look at the bladder pain as their own problem and work out for themselves. I mean, you can get some guidance by looking at the literature as to the obvious ones, the acidic foods, the spicy foods, the alcohol. Those are well known. And on the other side, drinking copious amounts of water is good. Now, here's a catch. Because we know that as the bladder fills, the pain gets worse. So there is a tendency to say, look, I won't drink much. So the bladder doesn't fill as much. But then you're concentrating urine, and now you got into a self-perpetuating cycle. So I think the answer is use your common sense about the color of your urine that you're producing, and make sure that as far as possible, you're as well hydrated as you can be.
Yeah. So in terms of elimination diets, is there one that you would recommend, or is it the idea is to see a dietitian who would recommend that? Who would? I think
there is enough literature on the various websites that deal with bladder pain that will give you some guidance. I think if you're lucky enough to have a dietitian attached to your general practice, or to your urology or urogynecology setup, they may be able to give you a leaflet. No, there is no real one rule. I think you've just got to use the resources that are available and just find out what suits you and your bladder pain.
Okay. All right. Okay. So can we talk a little bit then about the patient journey? What does that look like? What's the route to getting a diagnosis? What's that like?
Well, I think this is where the challenge comes in, because there's inevitably going to be a delay. When a patient complains of bladder pain, I'm talking about right at the start of the journey, one always associates it with cystitis. And the assumption is that there is an infection. And therefore, there is a tendency to prescribe, used to be a tendency to prescribe antibiotics. Nowadays, we're getting really nervous about the use of antibiotics, because we're developing resistance to the antibiotics, because the bacteria are getting resistant to them. And so we are a little bit more cautious about antibiotic use. And the problem is that you can have bladder pain attributed to cystitis, and on testing of the urine with the dipsticks be negative. So if you're not really sure, then it is a good idea for your general practitioner to send a sample to the lab to try and see if there can be a evidence of a growth of a bacteria, what kind of bacteria, and what do they respond to. So you can see in that process there's going to be a delay. So a lot of patients start off with frequency, going to the toilet very often, or they develop pelvic floor dysfunction. If you think about it, if your bladder is irritated, your whole pelvic muscle groups contract. So you've got the tension in the pelvic floor. So now you've got a knock-on effect on the other two orifices, the vagina and the rectum. So before too long, you know you've got pelvic floor problems, and then you run the risk of getting constipated or getting difficulties with intercourse. And this is why I think sometimes, depending on which of the orifices are involved, will dictate whether you go to the urologist, gynecologist, or coloproctologist. So it's important that when you present, it's the presenting symptom that dictates the GP's decision as to whether to refer you to secondary care or not. But I think if the problem is becoming recurrent and it is encroaching on your quality of life, then I think there needs to be a more thorough investigation. Now, we're lucky because in the last 30 years, we have a branch of surgery called urogynecology, where the specialist is trained in both urology and gynecology. So in other words, a woman has got two possible specialists you can see, a urologist or a urogynecologist. But the procedure is still the same. They will take a history, perform an internal examination, test your urine, arrange for you to have further investigations depending on how you present and what they find. They may ask you to keep a bladder diary, undergo urodynamics, which is testing how your bladder works to filling, and also putting a telescope either by as a day case or under local anesthetic or under general anesthetic to look inside the bladder to see if there's another cause for your suprapubic discomfort or bladder pain. This is so important for our listeners not to self-diagnose bladder pain syndrome until the treatable causes have been excluded by the specialists. And then, depending on what they find, they may choose different possibilities. Maybe.
Oh, Winston, I think we dropped out there for a short while. It's okay. We're back, everyone. It was at the point where you said you could have a camera to check the inside of the bladder. So if you could just pick up from there, please.
Yes, sure. So basically, a cystoscopy is putting a scope through the urethra into the bladder. It can be done under local anesthetic or it can be done under general anesthetic. What it allows the specialist to do is to exclude another cause of why the bladder is irritable. Because it's not just the cystoscopy to see the inner lining. You may see ulceration, you might see a bladder stone, you might see evidence of bleeding, whatever. So it's terribly important for our listeners to make sure that they get disease processes excluded before you say you've got bladder pain syndrome, and then follow the appropriate treatments as they decide. So the urologist will then do what they have in their toolbox. They might prescribe antibiotics. They might give you muscle relaxants to relax your bladder. They might send you to pelvic floor physiotherapy. They might, the choice is quite wide. But once that is excluded, that's when you get referred for pelvic pain management, of which bladder pain is one part of the disease processes we see in our pelvic pain clinics.
Okay. All right. So I've noticed we've got, we are the Vulval Pain Society. We've got people of all genders watching here. And I wonder, you mentioned that it's not as prevalent in men as it is in women because women have a shorter urethra. But are there significant differences in the way people experience this based on gender or on sex?
Well, I think the situation is a little bit more complicated because we have to consider the hormones. I'm talking about in women whether you're in the reproductive years or are you peri or postmenopausal, because one of the problems being peri or postmenopausal, you're more likely to get an irritation of the urethra and bladder as a result of the menopause. And we call that the genitourinary symptoms of the menopause. And for that, patients get dramatic relief from topical estrogen. And so it'll really depend on what your hormonal influences are. And for men, obviously, the prostate is a hormonal gland unique to males. It causes obstruction, and it can also cause cancer. So we're talking about the gender differences. The bladder is essentially the same in men and women, but the background contributing factors in terms of hormones are very different. And so those have to be excluded as well.
Okay. Now I've seen a few questions in here. Before we go on to those, can we talk a little bit, because we've talked about ways in which people can perhaps go on the elimination diet and see what their triggers are, drink more water. Are there other things that can be done? You have touched upon antibiotics, but are there other medications and other options for people if these things don't work?
Yes, I think first of all, let's consider conservative measures. I think you've mentioned most of them. Educating their patients, identifying your trigger factors and avoiding them, sticking to foods and drinks that suit you and are not bothersome for you. Don't make the error of restricting your fluid intake because you think, all right, okay, if I don't drink as much, my bladder won't fill as much and I won't get pain. But then the urine you're producing is very strong and concentrated. And paradoxically, that's going to make your pain worse. So using the color for your urine to be straw colored, especially during the hot weather when it's easy to become dehydrated. Your sleep patterns also are important. If you're getting up every night to pass urine, you can imagine within a few days, you're going to be shattered, physically and emotionally, because it is very draining. Regular exercise, not just the pelvic floor, but just for cardiac reasons, to be able to be healthy. And if necessary, getting some advice from pelvic floor physiotherapy. Or if you're passing urine, instead of hovering over the toilet seat, sit down and relax, because that allows the whole bladder to be emptied. And what may or not be surprising, if you're stressed out, if you're in acute stress, you feel like passing urine. It's almost like a normal reaction to sudden fright and flight. So reducing your stress, mindfulness is now becoming very, very high in the pain world, in reducing stress and reducing pain, because you're not producing the adrenaline that triggers it. And also just general attention that vulval pain patients are very familiar with. Not using tight clothing, not using synthetic underwear, avoiding detergents, not using hygiene products, and just not using perfume soaps or colored toilet paper, etc., etc. So it's basically good general health, wiping from front to back, that kind of philosophy. So those are the conservative methods. Mm. Now, the next one is a little bit more difficult to explain, because the logic says, if I've got bladder pain, I need to take a painkiller. Well, you start off with the non-steroidals. Men are usually given non-steroidals if they've got symptoms in the bladder or prostate. But the general rule is if it hasn't worked in 2 weeks, it's unlikely to work. So do the trial for 2 weeks and stop. Once you start going on to the opioids, of which codeine is the basic, morphine is the strongest. Nowadays, people will not be prescribed that because the risk of developing tolerance or dependency or reducing your immunity is going to be a bad choice. So those drugs are very rarely prescribed. You mentioned about the use of antibiotics, but I have to say, whether you take antibiotics, say, for a short, sharp burst, or whether you take them long term, or whether you just take them after sexual intercourse, because sexual intercourse, penetrative sexual intercourse, is one of the high risks of getting urinary tract infections and possible bladder pain. So those are kind of things that need to be prescribed by the specialists. In the pain clinic, we would go on for things like the antidepressants, like amitriptyline, which occasionally helps the bladder. You don't get that frequency, helps you sleep. So low doses of that in some patients may help. And as I said in the beginning, we really don't know all the causes of bladder pain. So sometimes a course of antihistamines might help. So it depends on really who you're seeing, what their biases are or preferences are as to what you get given. But I think as a general rule, if it hasn't worked after the stated time for it to work, then stop it, because there is no point in taking a medication for nothing. And the third choice, which we have in the pain clinic, is obviously filling the bladder with a mixture of local anesthetic and things like heparin, which replaces the gag layer. It's like repainting the inner bladder wall, the gag layer. So those mixtures will differ from urologist to pain specialist, because each one has got their own recipe. Just like cookery, everyone has got their choices and everybody thinks their mixture is the best. So it's a question of trial and error there. And then finally, obviously, surgery or more invasive neurological techniques in intractable cases will come. So I think generally speaking, conservative methods first, just getting your overall lifestyle improved, and then go on for the choice of medication, whether it be antibiotic or whether it be an antidepressant or anticonvulsant. That will be dependent on which specialist you see. And then bladder treatment. So those are the sort of kind of range, and surgery should be last resort.
Okay. There's some good advice here from Maria. Keep a food diary to figure out which foods are triggers.
Yeah.
Absolutely. Adrian says tea is a bad trigger for me. I wonder, is it the caffeine in tea, or is there something else in tea that might cause it?
For my reading, it seems to be the caffeine. And when I did a literature search a few days ago, caffeine-free tea, I believe fruit tea is tolerated better. So I suspect it's the caffeine molecule that causes the problem rather than the other constituents. So I think it is caffeine, and therefore tea might also be a problem for some patients.
Right. Okay. Okay. We've got a few questions here if you're happy to take them, Winston.
Yes.
Yeah. So any advice, please, if you have bladder installations for pain, can you still take antibiotics if you have UTI?
Now, this is a very good question, because it worries me talking about bladder pain. Bladder pain can be caused by infection. The only treatment for a proven infection is an antibiotic course. In the absence of an infection and just improving your quality of life, bladder installations are used. So I'm quite clear in that. Have you got an infection? You need the appropriate course of antibiotics for the appropriate length of time, either as a treatment or as a prophylaxis, a prevention. But if in the absence of an infection, then obviously installations or any other treatments that we've related to will apply. Now, for the men in the audience, I think there must be a few men listening to this. One of the biggest problems I used to face in the pelvic pain clinic is when the urologist would send me a male patient with bladder pain and say, I've started him on put him on a course of antibiotics, put him on a course of non-steroidals, and they haven't got better. Please see and treat. And the reason for that is that in the absence of an infection, there will be no response to an antibiotic. Yeah. Now, here is the catch. If I use the word inflammation, I think most lay people will understand if you've got inflammation, if you take an anti-inflammatory like ibuprofen or diclofenac or whatever is prescribed to you, then it should go away. That is what I call the classical inflammation. But when men develop bladder pain syndrome, they usually have no evidence of infection, no evidence of inflammation in the classical sense, but they have what we call neurogenic inflammation, i.e. the nerves coming from the bladder are irritated and the brain thinks, oh my God, there is an inflammation down below. Hence, urologists will give middle-aged men who are more likely to develop this problem a course of antibiotics and a course of non-steroidals, and only if that fails do they come to us. And it is amazing how big the numbers are. So it's a huge problem for the male patients.
Mm. And of course, if we're talking about this, if this is a neurogenic inflammation, if it's that instead, then we're looking at, again, multidisciplinary care.
Very much so. I think you've hit the nail on the head. Because if it's neurogenic, it's nerves. The only medication we have in medicine that helps nerves are the antidepressants or anticonvulsants. If you've got pain, the muscles around are going to get tight. So that's where pelvic floor physio come into it. If you have acupuncture and relaxes the muscles, you're going to get a benefit from it. So I think what I'm saying is, whatever your problem is, don't be afraid to look around at several therapies used concurrently as you add one to the other. In other words, say you get 20% benefit from a course of, say, amitriptyline, just for argument's sake, and you get another 10% by having acupuncture, another 10% by avoiding foods and stuff. And before you know it, you've got more than 30% reduction, which in terms of pain medicine, a 30% reduction for a chronic health condition is not a bad target to go for. So I would say to a patient, take all the possible avenues you've got available to you, because not everyone has got these opportunities, and find what suits you and add or subtract depending on whether it's effective or ineffective. But a word of caution, especially if you read sites on the internet and somebody makes a claim that this tablet, which costs £100 for a month's supply, and you think, oh, I'm going to have to try it because I'm desperate. You may find that you get a benefit for a little while, and we call that the placebo response. But what is really worries me is the nocebo, which is the negative side of a response to a medication, which causes damage to your health. That's my worry. So I'm really careful in recommending anything, and I'm very careful in trade names and stuff, because I really think we need to be fair to our patients and say the evidence base in most of medicine is limited. So all we can recommend today, for example, I'll just give you an example, cranberry juice. Now, I used to recommend cranberry juice to almost every woman that had recurrent UTIs or bladder pain. But if you drink the cranberry from the supermarket, it contains a lot of sugar. And that's the last thing you want to do. So cranberry extract tablets from your high street may be a better source of cranberry extract. The other the other three commonly recommended ones are vitamin C, D-mannose, which is a sugar, a simple sugar. It doesn't taste like sugar, but it comes from the sugar family, and methanamine hyperate, which is Hyperex, which is, if you like, a antiseptic. So what it does when you take Hyperex, it prevents the bacteria in your bladder from multiplying. So it's bacteriostatic, but not bactericidal, which kills bacteria. So Hyperex may be okay if you're taking it as a means of keeping the bacterial population down, but it is not good for a urinary tract infection where you need an antibiotic. So I think you've got to be really careful the distinction between an infection, which can be a killer if you become septic, and an inflammation, which is a feeling of like an infection, but is actually just an irritation of the bladder. That's why I think we need to be distinguishing the two concepts as to why people get bladder pain discomfort.
And if we're talking biopsychosocial model of care, of health, then, you know, potentially if there's that fight or flight mechanism involved, then psychological therapy's route. And you've already mentioned mindfulness,
Yes.
Things that could just calm the nervous system down.
I think a lot of it is you know, there are a lot of psychological interventions that are useful. One is mindfulness. I think mindfulness is probably the cheapest and easiest psychological intervention you can have. It is basically based on Buddhism, which is living for today, now, not worried about yesterday and not worried about tomorrow. So for me, it was looking out of the clinic window and looking at a pretty flower on a hedge and just enjoying Mother Nature, or enjoying the sunshine or the rainbow, or just going to the garden, or just going for a brisk walk and just getting your thoughts together. That reduces the cortisol level, the stress hormone from your adrenal gland, and that brings down the pain and discomfort. And the other strategy, which is acceptance, to say, okay, I've got a chronic pain condition. I'm not going to let it stop me. What can I possibly do to have a reasonable quality of life, given the fact I've got a chronic life problem? Just like if you had diabetes or epilepsy, the same needs to be applied to a chronic pain problem. Living with the problem, reducing the problem as much as you can, but allowing you to function in terms of physical and mental and emotional states.
Okay. There's a comment here. I became resistant to oral antibiotics after years of recurrent water infections. I now do gentamicin installations, and they seem to be keeping my water infections at bay. And for this person, it will be lifelong. What's gentamicin?
Gentamicin is a very aggressive antibiotic. I say aggressive because in high doses it can knock off your kidney function. So it is not something that we use without careful. In this particular patient's case, all the normal, what I call classical antibiotic choices don't work because her body's bacteria have developed a resistance to it. So by instilling the gentamicin into the bladder, it has a local effect, but without affecting the rest of the body, and in particular, not the kidneys. So that's why gentamicin installations will be beneficial. It's just like doing a domestos attack on the bladder wall and keeping the population down, and therefore keeping the symptoms down.
Okay. Right, so wishing you all the best with that to our viewer. Here's one here. I'm aware that a number of people, including myself, with suprapubic or urethral catheters suffer from excruciating bladder pain and spasms with very little which helps this, even given medication or trying to rule out dietary triggers. Are there specific reasons for this, and are there any suggestions for relief?
Well, it's a very good point. One of the problems with a chronic catheter use, say like somebody who's paraplegic or somebody who needs it for obstructive symptoms or whatever, or patients elderly patients in care homes, the importance of changing the incontinence pads or nappies regularly. These are kind of issues. Now, if you've got a catheter into the bladder chronically, that piece of plastic forms a nidus for stones and irritations. And if you've got a stone formation, you can imagine it's not just a smooth stone. It have full of crevices, places for bacteria to hide. So yes, a muscle spasm, the bladder shrinking down can be a problematic. Sometimes just a simple washout, a flushing of the bladder by the urology nurse or the community-based nurse may help. I think I can't give one answer because it just depends on what's going on in the bladder. For example, if you are more likely to get blood in your urine, hematuria, if you've got a blood clot in your bladder, that's going to be very painful. So I can't give you a global answer, but aware that bladder spasm is very, very, very painful.
Okay. So who would you suggest they talk to about this? Their urologist?
The urology specialist nurse is probably the best person because they deal with these complications every time. I think that they would be my first port of call. Okay,
great. Okay, so can vaginal atrophy cause this post-menopause? I think we touched upon that, didn't we?
Yes, it is. Nowadays, we call it genitourinary symptoms of the menopause, GSM. Yeah. Oh, it's just dramatic. If you're perimenopausal or postmenopausal with the genitourinary symptoms in the absence of a disease process, then topical vaginal estrogen can be dramatic. I'm a big fan of that, but I would pay caution as a non-surgeon to say, please make sure that disease processes are excluded first before you go to the empirical treatment with vaginal estrogen. And not all women can take estrogen. So there are going to be rules there are going to be some patients who are not suitable for that treatment.
Okay, all right. Now you're going to have to help me with some pronunciation here. Try to get a medication to control my bladder systems. Was prescribed solifenacin.
Solifenacin, yeah, solifenacin, yeah.
Okay, but it has a side effect of UTIs, so I don't take it. Is there a different one that doesn't have this side effect?
Well, I think it's beyond my expertise in that, remember, if you've got a bladder that's irritated, the muscle wall of the bladder is going to be hyperactive and get stronger. So solifenacin, the alpha blockers, the muscle relaxant ones, all these medications that urologists and urogynecologists prescribe, you have to go by trial and error, because not every person reacts to an individual drug the same way. So if solifenacin is not working, then ask your specialist for an alternative. And also, clearly, if you've got urinary tract infections, there may be another reason why you need to be seen again. So it's difficult to give a straightforward answer for that.
Okay. Any thoughts about D-mannose? You did touch upon that earlier. Could you just tell us a little bit more about that? You said it's like a sugar, but it doesn't taste sweet.
Yes, D-mannose is it's a simple sugar. It's used as a prophylaxis against urinary tract infections, or it's used in higher doses if you've got any urinary tract infections. It's a constituent of fruits like apples, oranges, peaches, blueberries, cranberries. But unfortunately, the amount of cranberries you need to achieve the same as the tablet is massive, so don't even bother thinking about it. However, there are a couple of cautionary exclusion factors. Be careful if you're a diabetic, and it can damage kidneys. So essentially what I'm saying is check with your GP, check with your specialist if this is a suitable choice. The commonest side effects are bloating, abdominal bloating, loose stools, and a bit of diarrhea. How does it work? Well, the most common bacteria that causes urinary tract infections is E. coli. And they have little villi with little sort of mini tails. And those tails latch onto the bladder wall, and that's how the bacteria sits on the bladder wall. And what D-mannose tends to do is to prevent that from touching. So when the patient drinks water and passes urine, it flushes it out. That's how it works. The methanamine hippurate, which is Hippurex, is actually an antiseptic. It's anti-infective. It doesn't kill the bacteria, but it doesn't allow the bacteria to grow. So it's not good for urinary tract infections, and it works just by acidifying the urine. So the bacteria are now in a medium that is not suitable for them. So it's good for those patients that have recurrent urinary tract infections or those with catheters in situ, but you've also got to be careful about side effects, impact on the kidney. So check it out. And the third alternative, which is becoming trendy, is vitamin C, 0.5 to 1 gram daily. Vitamin C is acidic, and maybe it's the acidic effects that help it work. But vitamin C prevented scurvy in the Navian days when vitamin C was a problem in diet deficiencies in vitamins in fruits, etc. But it may also be its acidic effects that cause its effect. So those are the three sort of non-antibiotic therapies. And I talk to my patients. Each one finds one of those or a combination of those the best for them. But my word of caution is, please let your GP know and your specialist know what you're taking, because there is always a possibility of drug interactions working with other medications you may be taking, or they may be not healthy for other medical problems that you may have coexisting. So just be sensible before you self-treat.
Yeah. Okay. All right. I've also got sacral nerve stimulation for chronic urine retention. Might that help with interstitial cystitis pain?
That's very difficult to say, because I think you have to be really, first of all, what is the cause of your original problem to have the neurostimulation, and what are you trying to solve? As a rule, the more invasive a intervention is, the fewer the patients that are going to respond to that treatment. So it's like a pyramid. You start with the basics, and then as you get more and more expensive and invasive treatments, far less patients get benefit. The other thing is, just be very careful. Just because you've got a stimulator that can also be used for pain, can also be used for other conditions like bladder filling and other choices. Try not to lump together different symptoms and expect one magic intervention to treat both. So the bottom line is, discuss it with your specialist and just ascertain as to whether there is some evidence base for what you're trying to achieve.
Okay. A couple of people have mentioned amitriptyline, and someone I think I've seen, for this person, amitriptyline seems to make things worse. Is that a thing? Yes,
I in clinical practice used amitriptyline a lot because it's one of my favorite drugs, because It has got bad press because it's an old drug. It's an antidepressant, and just if you put somebody on an antidepressant, patients get a bit worried about being labeled as having mental health issues, or they're worried about what the neighbors will think or family will think because maybe somebody in the family had it for depression, etc., etc. So there are some social disadvantages, if you like. However, the dose for bladder pain is much lower than for depression. So I'm talking about 10 to 20 milligrams as opposed to depression 50 to 200 milligrams. And you take it early in the evening at 7 o'clock because you don't want that sedation and dry mouth effect to occur in the morning. And it takes 6 to 8 weeks to work. It doesn't work instantly. There's a lag time. What I find, just from personal experience and also from my experience with my patients, if you give somebody amitriptyline, the first thing they'll benefit from is a better sleep. So if you're waking up every night to go and empty your bladder, that sleep enhancement effect may just be another bonus. In about 4 to 6 weeks' time, the pain or the discomfort may reduce, and 6 to 8 weeks' time, your mood is elevated. If your mood is elevated, it's a chicken and egg situation. If you pain, you feel depressed. If you got depression, you'll feel pain more. So you get sort of a double whammy for your medication. Now, remember when we first started this chat, Sheren, I said to you, you are likely to have more than one pain problem. So, for example, if you've got bladder pain, you might also have IBS. Now, amitriptyline constipates you. So it may make your constipatory IBS worse, but if you have diarrhea IBS, you'll be better. So I think at the end of the day, you have to choose. If amitriptyline doesn't work, or like the patient that asked about the amitriptyline, it is also worth trying the cousin, nortriptyline, which is less constipating. So, so what I'm saying is my first choice would be amitriptyline, and my second choice would be nortriptyline.
Yep. In
low dose than for depression.
Yeah. Okay. A couple more we'll take before we wrap up today. I was on cimetidine for years, yes, but it's now unavailable. So they've put me on famotidine, but they're not working as well as the first one. You will challenge me with the names of drugs, won't you?
Do you remember when we talked about histamine in some patients being the chemical that causes bladder pain? Now, histamine comes from two lots of families. It comes from H1, H2 receptors. They're two different receptors. Cimetidine is good for histamine release, if you like, within the stomach. So some urologists will use cimetidine as opposed to another choice, which is something like hydroxyzine. Now, if you think about it logically, here's the issue. If you take cimetidine, you reduce the amount of acid in your stomach. Now, the reason why acid is important in your stomach is that it acts as a protection for bacteria from going into your gut and colonizing it. So if you reduce the acid potential for the stomach, you're more likely to run into problems of colonization of the gut microbiome. And as everybody knows, if you mess up your microbiome, your health goes down. So I think the days of using cimetidine we're becoming more cautious about it, because when you think of any therapy, I always ask my patients to think about how effective is it, at what price, both in terms of cost, especially if you buy it privately, and two, in terms of your overall health. So I think you've just got to see the bigger picture before excluding something. It may be that your specialist could not give you other choices, or it may be that you have to abandon that choice and try something else.
Okay. Now I've spotted something here. What was it? Oh, it was someone just mentioning it's the tannins in tea for them, not the caffeine that's the issue. Chamomile, plain rooibos, safest ones for them. Again, this is trial and error to see what might be okay, what you might tolerate yourself. Let's have a look. Any thoughts on prophylactic antibiotic other than Monuril? It has orange and lemon flavoring in it, which acts as irritants for an already irritated bladder. Why on earth do they start flavoring things? It irritates me in all sorts of other ways.
Well, I'm going to be really careful here, because I'm not a urologist and I'm not a renal physician. So all I will say is your choice of antibiotic, whether it's used as a treatment for a urinary tract infection or as a prophylaxis against recurrence of a urinary tract infection, or as a protection after penetrative sexual intercourse, must be prescribed by a specialist who knows what they're doing, because antibiotic stewardship, in other words, the restricted and scientific use of antibiotics, is important globally if we are not going to run into problems of super resistant bacteria in the future, because less and less antibiotics are becoming available now. So prophylaxis is really managed by the urology and or renal physicians, because that's their specialist area. But don't expect antibiotics to be given out as freely as we used to do 20, 50 years ago.
Okay. How does bladder distension work at reducing symptoms?
This is a really pointed question. I was hoping nobody'd ask this question, because in interstitial cystitis, which is, remember I was saying to you, it's the worst possible form, the bladder capacity seems to be contracted. Now, as an anesthetist, a general anesthetist, in my time, I must have anesthetized for urology for about 30 years. So in IC, that's the really extreme. So there are very few patients with IC. Most patients have BPS, bladder pain syndrome. We used to put them asleep, and then the urologist would fill a bladder from a bag hanging high up, so it distends the bladder wall. It is very painful. It cannot be done under local, and even under general anesthetic, you can see the evidence of pain being experienced by the patient in terms of the heart rate going up, the blood pressure going up, the tears, sweating. So hydrodistension works just by expanding something temporarily. It's not a cure. It's a temporary holding pattern, if you like. But it does not apply to the routine bladder pain syndrome. It only applies to that small group at the end of the spectrum, the severe group, that might benefit from hydrodistension, because the vogue for doing hydrodistension is getting less and less, because what you don't want to do is to rupture the bladder if you've got a weakness in it. So there are issues, and I think that's best discussed with your urologist or urogynecologist.
Okay, all right. Now, I know that there have been a few more questions, but we're sort of at the end now. Let me just see if we can squeeze one more in. I think, yeah, no, we'll have to wrap up at the moment, but, you know, do comment, and if we can, you know, get to answering these at a later stage, we'll see whether Dr. Winston might be able to answer them and pop the answer up. We've covered quite a lot of ground today. So as with all our live streams, if you wish to rewatch it from the beginning, or you haven't caught all of it, these live streams, the recordings remain up on our Facebook page and our YouTube channel. And I've popped up those links in the comments. Winston, any last thoughts, perhaps some top tips before we finish for today?
I just want to say to the listeners, about 2 years ago, Julie, my specialist nurse, and I produced an article for the Bladder Health Charity in Birmingham. And the notes on bladder pain syndrome will be on the website after this, hopefully in the next few days. My hot tips, I've got 10 quick tips. Drink at least 2 liters of water. Avoid triggers. Do not smoke, because that's nicotine, which is triggers the bladder. Keep your weight within normal limits. Use the bathroom every 3-4 hours, and after intercourse, take time to fully empty your bladder by adopting a relaxed position, wipe front to back after going to the toilet, wear loose-fitting clothing, exercise for cardiac reasons and pelvic floor, and finally, never give up or lose hope, because we hope that podcasts like these, live podcasts like this, can at least help one patient, perhaps of those listening today, and might offer them some sort of options that they may not have understood or realize what is available, and hopefully put things into perspective.
Thank you so much, Dr. Winston de Mello, our very own Dr. Winston de Mello. Thank you so much. That's super informative. And just to say thank you, we've had a brilliant number of viewers this evening live, and I know there'll be plenty more watching this and the replay. We've covered a range of vulval pain topics with some really excellent multidisciplinary clinicians and researchers this year. So I would encourage you to go and have a look at those. I've put those links up because I've noticed there are questions about when will you cover X, Y, Z, and actually we've covered some of those areas. So a quick run through of what we've covered. We've covered gynecology and pain clinic appointments, physiotherapy with a couple of specialist physiotherapists, vulval skin conditions. We've had a couple of sessions on that. Vulvodynia research, psychosexual medicine, again, a couple on psychosexual medicine, vulval cancer, menopause. We've had a couple of menopause experts on so far. Vaginal examination in labor and consent, the gut microbiome and its role in pain. That was a really interesting one. Pudendal neuralgia we've covered. Sleep and physical health, the connection between the two. We touched upon sleep earlier, and there's a whole live stream recording on that for you to watch. And today, of course, we've covered bladder pain syndrome, and the other end of the spectrum, interstitial cystitis. So now it's over to you. What would you like to see covered in future live streams that we haven't already covered? Please pop your comments up or message us, and then we'll likely run some polls on social media, and we'll see what you'd like covered, and we'll get them covered by experts. If you're a clinician or you're a researcher working in the area of vulval pain and you see that there's something we haven't actually covered yet, get in touch with us. Or maybe even something that you yourself might like to come on and cover, reach out and tell us about it. So the next date for your diary is Wednesday, the 6th of October, and we'll announce who our speaker will be soon, depending on what you tell us you'd like to hear. If you like or follow us on Facebook, on Twitter, on YouTube, you'll be notified of the topic and speaker. Otherwise, of course, just keep an eye on our website, where we will also announce details. Talking of which, you will find plenty of useful resources on our website, vulvalpainsociety.org.uk. Whether you experience vulval pain or you're a healthcare professional, plenty of resources on there. And as Winston said, the article that he wrote for, was it Bladder Health UK? That's going to go up on our website shortly as well. So you'll have something to read following today's live stream. So if you want to reach out and get in touch with us, you can email to info@vulvalpainsociety.org.uk. But otherwise, find us on social media. Thank you again for those of you who already follow and interact with us. If you share posts and retweet, it really, really means that we can help you better and reach more people. That is all from the Vulval Pain Society for now. Thank you again, Dr. Winston de Mello.
Thank you, Sheren. Thank you for hosting the show.
And thank you for Kay and Catherine from the Vulval Pain Society in the background on YouTube and Facebook. And a huge thank you to all of you for joining us live or on the replay. Bye for now. Hope you can join us October the 6th.
Good night.